Good afternoon, everybody. You know, I'm really blessed to have what I consider is probably the best speaking slot of the entire conference. Normally, it's a great thing to be the guy that goes first after lunch. It's also great to be the guy that goes first after a brilliant, witty scientist. Right, okay. Well, I never met Rajan before, and maybe she just doesn't like me. So we're going to talk about some interesting stuff today. I think you'll like it. I mean, certainly there was a whole lot of complexity that Dr. Mosley brought up that we all are dealing with on a daily basis. What I'm going to try to do today is give you some tools to manage that uncertainty. I'm going to try to give you some tools and a roadmap to help better integrate this material into what you do. And we call it Crossing the Chasm. So this presentation is going to start the way all great presentations always do, with a disclaimer. Oh, it's not that exciting. So, you know, I am on active duty in the U.S. Army, and so it's because of that I've got to draw out my little disclaimer here, that you'll notice I am not wearing my military uniform. The military uniform does not look like this. A little bit of a different shade of blue, and they don't like the yellow tie. But just to let everybody know, the views expressed are my personal opinions, and this isn't about the Army or the Department of Defense or anything like that. So that is the worst slide in the deck. Are we good? It only gets better from here. And no graphs. Yeah, you're welcome. All right. So let's start with the question. The question's, why are you here? Now, I'm not asking if you paid. Hopefully we've worked that part out, right? If you haven't paid, please raise your hand, and someone in one of those colorful vests will come pick you up and escort you to the back of the room. What I really am asking is, why are you at a pain science conference? It's probably likely that you're noticing the same thing that I am, is that the material that Professor Mosley covered this morning and the material that we're finding out in pain science and neuroscience really changes what we do at a fundamental level. And it's not always easy to take that and bring it into what we're already doing and make a cohesive whole of it. But that's what we're going to try to do a little bit today. I think this information has made us lost. If you're sitting in this room, you're probably not as lost as the average bear. But for the most part, we need to tell a story. We need to tell a story about getting lost and about finding your way. We're lost for a reason. We're lost because of the change in our scientific foundation and footing has shifted, that has rendered many of the concepts that we use to treat patients, to take care of clients, to train clients. It changes those things. It's not an easy thing to bring that in and change what you're doing. In order to appreciate that you're lost, you have to actually notice. Now, as a man, I'm not often good at that part. We're lost. No, we're not. Honey, I know where we are, but I usually don't. That's okay. So where are we lost? I contend that we're lost in a gulf of uncertainty, in a space where we don't exactly know where it is we need to go next. Our experience of pain, movement, motor control, and human function doesn't always line up well with the training that we had in our professional programs and with the culture of medicine, therapy, and training. And we need to find a way to negotiate that. We're lost in that uncertainty. And the name for that uncertainty is the chasm. I don't know who originally called it the chasm. Usually when something like this comes up, I blame Barrett Dorco. And that's what I'm going to do again today. You don't like the chasm? That's the guy. Blame Barrett, right? Our challenge is how we cross that chasm, how we get from where we are, our current understanding, our current practices, and how we move to where we need to be, how we get to the other side of that chasm. Now, what is the chasm? So I used to think that the chasm looked like this. I thought it was a fissure, and we just needed a bridge. You just need a bridge to cross from one side to the other. Pretty clearly, we've got to go from left to right? So I thought this bridge is information. I thought, you know, people just don't know all this great information about pain science. They don't know what neuroscience has told us about pain, movement, motor control, and human function. And if we just tell them, they'll be like, oh, thank you, Jason. Thank you for telling me that everything I've been doing doesn't make any more sense, and I got to totally throw everything out I'm doing and totally, completely change. Well, you know that concept that people just need information in order to make a change? There's a name for that. It's called the information deficit model of communication. And wow, is it wrong. And after having kind of knocked my head against maybe the computer screen, but also maybe some conversations about how to make this work, I started to realize I think we need to reconceptualize things. So I don't think this is the chasm. I think that's the chasm. It's much bigger. It's got a lot of different varied terrain. And you need more than a bridge. You need a navigation system. So what's a navigation system, right? It's not a physical tool, right? It's not the box that your nav system comes in. It's not the case that's on your phone, right? A navigation system is a way of making decisions. It's software, not hardware. And so here's what makes a navigation system up. It isn't a question of a tool, right? A tool can't tell you when to use it, how long to use it, for which situation and how long. That kind of toolbox mentality, we've really got that a lot in the medicine, therapy, and training world, don't we? We have this idea, if I just go learn this technique, and they're having this weekend course over here, I'm gonna go get those letters, and there's some tape, and there's some needles, and there's a kettlebell, and what else have I got, right? And you look around for all these things to collect. If I just have enough stuff, there's a term for that. It's called hoarding, right? Maybe that's the wrong way to go, right? We need to get a little bit better software. So when I talk about the concept of toolbox, I like to make the distinction process versus product. And, well, thank you for asking. The full text of that letter of mine is available online. Thank you for asking. Check it out. What we need a system. We don't need tools, right? Those eclectic or toolbox methods of all those different things, that's not going to help us, right? So when we talk about products, what's a product in terms of a navigation system? It's a left turn. It's a right turn, climbing stairs, going up and down. That's how we navigate, right? That's a product. The process is the algorithm inside that helps tell you where to go. It's the software, how you make decisions. That toolbox approach is usually disorganized. It's centered around applying products, not using a process. Navigation products, as we talked about, those left turns, right turns. What does it mean to say that you're a left turn specialist? Where do you go if you only left turn, right? You just go in circles, right? That's not what we're looking for, right? Sometimes in life, you need to go right, right? Sometimes you got to go up, sometimes you got to go down, right? Having those different methods is important, right? Usually in a toolbox system, people will take their favorite tool at the moment, and it might change month to month because, I went to a new course and I got some new letters. And guess what I'm all about now? I'm all about this tool over here. So we'll use our favorite tool and kind of throw it out. If that's not working for the client, if that's not working for the patient, we just reach in, where's that box? There's got to be something else in here. We reach and put that next tool into practice. That's not the kind of algorithmic reasoning model we should be looking for, right? So we don't want to see those other things we do as some sort of fallback. So what I want you to do is dump your toolbox. I want you to open that puppy up, flip it upside down, give a good shake, get all those things out of there. Once you learn a process of care, a system of reasoning, it will help you work towards these concepts. It lets you work toward different goals. It lets you use with a variety of clients or patients. It lets you be consistent with the published evidence, and it helps you integrate new information. Was there any new information that Dr. Mosley went over? Most people are familiar with most of it, but a lot of it is very new. We've got to find a good way to integrate it. So, let's talk about that. Let's build together a navigation system to get across this chasm. Let's look at the principles behind that a good navigation system has. What are the principles there? Not brand names, right? I'm talking about principles. In order to be a good navigation system, it's got to do three things, right? It's got to accurately reflect the ground, it's got to recalculate the route, and it's got to give you an accurate picture of when you're going to get somewhere, right? Those are the big three things in a nav system. There we have it. Anybody used a nav system in the phone, on their car? Most of us, right? It's 2015, everybody knows how these things work. Have you ever been driving along and the little woman who lives inside the box says, take a left turn at Smith Street? And you're driving and like, there's no Smith Street there. And then usually she won't say it once, she'll say it again. And the second time, she has a tone. Take a left turn at Smith Street. Like, there's no Smith Street there, right? There's no turn to make. That's a nav system that's not accurately reflecting the ground. The other thing it is we've got to be able to recalculate our route, right? This is what I get a lot when I use the nav system. I make a wrong turn. It has been known to happen. It has been known to happen. We all make mistakes. It was in 1978. I remember it very clearly. Make a legal U-turn when possible. Anybody heard this one? Make a legal U-turn. No, what if I don't want to make a legal? Don't tell me to go back the way I came. Show me a new way to get where I'm trying to go now that I'm here. And isn't that what we've got to do with this material? The other part it's got to give you an accurate prediction of when you'll get somewhere. My nav system sometimes tells me that I'll be someplace in 10 minutes. And it takes 20 minutes for all those 10 minutes to tick down, right? That's not a good, accurate prediction of when I'll get someplace. If we think about how we make principles of a nav system work for all of us, use these three principles to help guide us across this chasm, to integrate this new information, to give us a system of reasoning and a systematic way to apply these concepts, this is what we're looking at. And here are the three principles of crossing the chasm. You have to know the science, you have to apply a critical thinking process, and you have to use claims responsibly. So I'm all about small numbers, because after 4 I get lost. So these are the big 3 things. So if you're taking notes, you got a nice padfolio. These are our big 3 topics today, right? As the complexity of the system increases, the rules that govern your behavior need to get simpler, not more complex. That's pretty important, so I'll say it again. As the system gets more complicated, the rules that govern your behavior need to be simpler, not more complex, right? And these 3 concepts are your simple system. Where did this come from? It probably came from a conversation I was having with Will Stewart in about 2011, where he just looked at all these different, because we talked about all these courses and all these tools and all this nice nifty stuff. And he's like, I just don't think I need all these new approaches if I just know the basic science and use critical thinking. So it would be him up here instead of me, but I added the one thing and then said the other 2 were really my thing anyway. So here we are. So when we talk about number 1, we talk about know the science. I really like the number 3. So all of our main points have 3 subpoints. If you're taking notes, you're welcome. The 3 parts of basic science, the published evidence, and the context. This is to make sure that your understanding of the world in your nav system is the same as the world actually is. I have to keep looking down so I don't fall off the podium. That would be awkward, right? That's how you make sure that what's in your nav system in your mind is accurately reflected with what the evidence is. So the first, when we talk about basic science, when I say the term basic science, what does that mean? I'm talking about foundational science that drives what we do. I think there were 13 different professions represented here, right? Something like that. No matter what you do, maybe you're in the performance world, strength and conditioning specialist, personal trainer, you're in the massage, you're in the rehab industry, in the medical industry in some way. All of these things are the basic science that drive what we do. Now, if carpenters and architects knew as little about houses as many people in those industries seem to know about people, we would have buildings falling down all around us, wouldn't we? Because we got a lot of ideas out there that don't necessarily reflect what's really going on for the basic science. Most of the really questionable treatments and approaches out there, we've all seen them, right? You can really avoid getting involved with those if you know your basic science very well. So as we go down that list, what jumps out at you? Paints, well, because I put it in yellow. Right. Work with me here. It's in a larger font, too. So, right? There you go. It does. It jumps out. It popped is what it did. That's what they say in the industry. It pops, right? So you'll notice that in this list, pain science isn't different or special. We don't have different categories of basic science that drives what we do, right? We're not going to break things out. It's all part of the same piece. We don't have the pain science over here, and then we have the biomechanics over there, kinesiology over here, psychology over there. All of these things we need to integrate at once, right? Because when science changes, that should change why we do things, what we do, and for what reason, correct? That really should change those things. These concepts are all in play. This kind of science is all in play all the time. Sometimes we'll talk about this as, oh, well, That's only for the pain science patients, right? What's a pain science patient? What kind of sense does that make? So if you're in the gym and you're instructing a patient in a new exercise, you wouldn't say, stop, I'm now going to talk about biomechanics. Come right this way, let me show you this exercise. I mean, you wouldn't do that, right? You wouldn't parcel people out. You wouldn't parcel out your thinking in different ways for other issues. Yet we're so willing to do it for pain science. We're so willing to label our patients, our clients, and the issues that this applies to is somehow special or different. A big part of that so we don't have to change what we're already doing, right? So we don't have to change what our thought process is. But we decided before, it's got to change. All these things are what one of my mentors calls software programs running in the background. So if you double tapped your home button, wherever that is, I'm not sure, and you looked at all the programs that were running in your background, these should be running in the background. That's my iOS version. I don't have an Android version of that. Just work with me. Right. Okay. So you can't divide your patients and your clients up into different areas. So why is it so hard? Why is it so hard to sometimes bring this part of basic science to bear? Right? Why does it challenge some folks? I think it's for these three reasons. It does add complexity, it is unfamiliar, but mostly it's because it challenges underlying assumptions. Assumptions we don't often realize that we've made. Things that we don't even put into words, but that underlie a lot of what happens in medicine training and therapy. Let's see if some of these assumptions are familiar to you. So if we think about a postural structural biomechanical model or a mechanical structural model, however we want to name that, and we want to think about the assumptions that underlie that approach, this is, I think, the three assumptions. So when you get into a conversation or you talk to somebody who's really into this model of care, whatever it is they do, one of these three assumptions is active at any given time, usually more. First is pain and movement are a question of the health of the connective tissue, right? We wouldn't be fusing spines if we felt otherwise, right? And we are still fusing spines, at least in the US, at kind of an alarming rate, right? And there's a linear response to provocation of the tissue. And so I said there wasn't a graph, but I'm going to make a graph with my hands. Does that still count? So the linear response looks like this. If you push 100, you get a 100 unit response. But we know our clients and patients aren't like that, are they? On some days, a small provocation gets you a big response. Other occasions, a large provocation gets you a small response, right? That's that complexity that we have to deal with. To get better, to move across the chasm, we have to realize where we are. And where we are has a lot to do with the assumptions of the structural model. Note, these are all false, right? Got to make sure I say that. So when we integrate pain science, when we integrate neuroscience into what we do, it does increase rather than limit your vision. It does make your navigation more complicated. And it's unpopular because it demands reading, understanding, and complexity. People don't like complex. People like simple. Oh, do this because of that, right? That's why the short weekend courses are so popular, where you learn a new tool, you get a new letter, something like that. Oh, everything lines up according to what you've been taught. We've got to be able to integrate this material a lot better. A lot of times, this material can be threatening to what people do and how they approach it. And they'll often try to push back and say, no, remember, we're working with patients over here, we're working with clients over here. That pain science stuff is for these people over here. It doesn't apply to what I treat athletes. Pain science doesn't apply to athletes. Have you worked with an athlete before? Pain science is appropriate for everybody. So what's our orientation of this material? This should be our orientation of this material. The biopsychosocial model that incorporates all this is bigger and contains all those structural concepts. We haven't forgotten about that. We don't leave that behind. We didn't put biomechanics out of our mind. We put it in its place. Now, for some clients, for some patients, it's critical. For a lot of other people, not very relevant. How do you work that out? You got to use your nav system. But notice how this adds more detail and more complexity. So when it comes to basic science, pain science or otherwise, there really aren't any shortcuts. You really do have to know it, and for most of us, it involves a lot of reading. Some of our professional programs prepared us very well in this regard. Some of the professional programs do not. But no matter how many letters you have behind your name, no matter how nice your school was, you're not immune from needing to know this material. right? All those letters after your name and all those diplomas on your wall don't guarantee that you're staying up to date with this material. And as you do that, you'll notice sometimes when your basic science knowledge increases, it renders whole approaches indefensible. That's where the concept of science-based practice comes from, right? So whatever it is we're doing, we need to make sure that's consistent with our basic science. Most of the things we're out there doing, regardless of what they are, the common approaches in physical medicine, common approaches in the training room, common approaches in the massage industry, can be retrofitted and can be used with a more accurate explanation. Very rarely do you have to just stop doing what you're doing. More than that, you got to change the way you approach it. You got to change the way you explain it. Ideas not consistent with basic science must be rejected, right? That's that foundation of the house. Memories are not stored in fascia, right? There isn't an energy system in the body that we can maneuver with our hands, right? Some of those things we just, at some point, need to stop talking about, right? When they're so far removed from what the basic science tells us. And really making sure your basic science knowledge is up helps you make those distinctions. And they're critical distinctions to make. So I got to have the obligatory Dr. Tyson quote and picture up when we talk about those things. So we talked about basic science. The next step in our NAV system is knowing the published evidence. Every profession has got a set of evidence, a system of evidence that applies to it, right? No matter what your background or profession is. You should know which direction the literature goes in your field. You should know the top systematic reviews and top randomized trials that apply to what you do on a daily basis. And yeah, you probably should be able to name a few off the top of your head, right? You should have that kind of familiarity with the published evidence in your field. And you need to stay up to date with evidence with both push and pull methods. So what do I mean by push and pull? Right? So a pull method is when I'm confronted with a patient or case or a situation that I don't fully understand, and I need to go to the literature and pull the information down, right? That's pull. The best source of push evidence that I know, where evidence comes at me whether I ask for it or not, right, is being connected to the people in this room. Because my social media contacts share a surprising level of detail and level of new science all the time. If you're on the Twitters, if you're on the Facebooks, and all that kind of stuff, get connected with the people who are speaking, get connected with the people that you meet at the conference. That's a great form of push evidence, evidence that comes at you. Oh, hey, look, I just opened up an email, and there's a list of a table of contents of some of the big journals in my field and what they have to say this month. Let's go through and see if there's anything of interest to me. That's push evidence. You need to have both to stay informed with what's going on in the literature. And the last part of that basic science is you need to know the context. Now, I know we're all very proud of what it is we do. We're all very proud of our professions, and justifiably so, because people in this room and people in our professions all over the world are helping people move better, feel better, and have less pain every day. But people do have choices about where to go and what to do, and the world isn't all about what you do. So I'm a physical therapist. Life isn't all about physical therapy, right? So it's important for me to make sure that I understand what else is going on in the world, about how to take care of patients in the way that I do, so that I can understand what the options are, so I can advise people accurately. If you're a young athlete and you've dislocated your shoulder and your shoulder's unstable, am I the guy for you? Well, I can reduce your pain, I can improve the mobility of your shoulder, I can help strengthen up the muscles that are injured. Can I keep your shoulder from dislocating again? No, I can't. For that patient, surgery is a better option. The only way I know that is because I know the context and the data around it. So whatever it is you find yourself doing, get in your local area and find people who do different things than you who can help your clients and patients with that kind of contextual information. Knowing the context really helps you make judgments about what is and isn't important. Because most of us, despite our best efforts, we sometimes spend a lot of time talking about and sometimes arguing about things that often aren't all that important, right? So people like to argue about things in that way, right? But knowing that context is key. Don't put a microscope on your world, pick up your head and look around at what's going on. So there's always some contentious issues in the field. So one of the contentious issues in the field of physical therapy, I mean, I know that best because that's what I do, is the concept of dry needling for trigger points, right? So let me take an informal poll. I promise it's not a trick. If you use dry needling and or you like it, raise your hand. Oh, be brave, folks, come on. If you don't like dry needling and you think it's terrible, raise your hand. What's everybody else think? I got like 6 hands that whole time. All right, good. No, I like that it's not an either or. I like that it's not an either or. We'll talk about why that's important in a little bit. I don't needle myself or my patients. I realized I had to clarify that statement a little bit, didn't I? I can't just leave it like that, can I? No, I don't needle myself or my patients. And so dry needling is not something I do. I don't think the issue of dry needling is a huge problem in physical therapy. I have talked to some colleagues who think that it's, I don't know, the coming of the most awful thing that could ever happen, or the key to transforming the world and making everything beautiful and wonderful and bringing unicorns and rainbows and all that stuff, back, right? So, at least in physical therapist practice, dry needling is being done by highly skilled practitioners in a medical context, by people who have rigorous education, is provided in a package of education, exercise, and movement, and is done for short periods of time. And the comparative interventions from other professions, like for example medication or surgery, are much more invasive and have a much higher risk profile. So am I worried about dry needling? Not a lot. I would put dry needling up against a 6-week trial of NSAIDs or an elective orthopedic surgery any day. So even if I don't use that myself, knowing the context helps me make a judgment about it. Now you may look at that same information and you may come to a different decision than I do about how important it is, and that's okay too. That's okay too. But that's an example of knowing the context around a situation and using that to your benefit. At the end of the day, science is hard, right? Knowing it's hard. For most of us, it involves reading. Sometimes lots of reading, right? We all do have to put the time in. Education didn't stop when we graduated from our professional program, right? The key to adult learning is repetition, which is why repetition is the key to adult learning, right? And that's how you maintain your knowledge over time. I'll start a resources thread on Soma Simple, where we will collect a bunch of resources, how to find push evidence, how to find pull evidence, how to find sources out there that are free that go into detail on basic science. Would that be of value? I'm hoping it would. But science alone isn't enough. Far too many times, we don't have a complete picture of evidence and we don't have a complete picture of basic science to help guide our decisions. There really are a few studies out there that precisely describe what we're doing, wherever it is we're at. And sometimes you need to change your approach. You need to reroute your path. And that's when you can just hear the GPS in the background going, recalculating, right? You need to be able to change that. Clinical practice, working with clients, working with humans. Who doesn't work with humans, right? We're all working with humans regardless of what our profession is. It's an art. It's an art that has to be informed by science. So what do we do when science isn't enough? It's important when you reroute your path to apply a critical thinking process, right? So what does this involve? It involves practicing humility and not taking sides. I like that there weren't a whole lot of definitely yes or definitely no answers to the dry needling question. That was good to see. You have to welcome critique and feedback, and you got to change with the evidence, right? Let's review those. So when I say critical thinking, what do I mean? Well, I've got a dictionary definition for you there, which may not be all that helpful. It's definitely not a critical thinking course, right? But it just gives you a picture of it. We do have to understand a couple of points, and I would say that while this is the dictionary definition of critical thinking, this is the social media definition of critical thinking that I sometimes see that is for me. So that's a lot of text, so I'll go ahead and read it off for you. So what critical thinking isn't: learning to use the language of critical thinking, including logical fallacies and biases, to dismantle the arguments of the opponents and win debates on social media without ever applying the same standards of evidence to yourself or your own thought process, so you can remain sure that you're right and they're wrong, right? Right? Who's seen, have you been to Twitter? It's a scary place sometimes. Other times it's a wonderful place. But sometimes these discussions go wrong, often because we are not fully applying that critical thinking. My friend Lars talks about how there's external critical thinking that you apply to others, and there's internal critical thinking you'd apply to yourself. I'm not interested in so much in whether you can apply this to other people. I'm most interested in helping you apply it to yourself, right? That's where you really make your money, so to speak. Because intelligent people, and you wouldn't be here if you're not intelligent, after all, you're watching me speak, are good at what the psychological studies say they're good at. They're good at spotting the flaws in other people's arguments. They're not any better. They are no better at applying those same standards to themselves, right? And we need to learn how to do that better. So this is our three-step apply critical thinking process. We need to do all three of these things well. The first part of humility, I like this concept from Chris Johnson, and I know it is after lunch, and it's a slide about fractions. So it'll be brief, I promise. Where he says, speak in denominators, not numerators. So remember the numerator's the top number? With me there? Okay. I know fractions was sometimes a long time ago. It was for me. I always appreciate a review, right? Half of humility is knowing the science. When you're familiar with the published evidence, you start to be less excited about how something new that comes along could be a miracle cure to whatever it is that ails us, because you've read too many trials, right? Chances are very good that we're all maybe not as effective as we'd like to think on our best day, especially if you're familiar enough with the evidence to know what the trial evidence is, right? So you tend to remember the numerators, the people you helped. Oh, man, it was great. Had a patient come in this Monday, had a client come in this Wednesday. I did this new thing I just learned in my course. They did awesome. And they went from here to here, and it was amazing, right? Those are the people you remember, the people you really help. What you probably are forgetting is the total number on the bottom. You're probably forgetting the denominator, right? And realize that unless you're objectively tracking that, put your mind in that focus. Put your mind in the focus where you're thinking about the total number of people out there informed by the evidence and by your experience. Another part of being humble is not taking sides. So I see this a lot. Well, is this a pain science issue or a biomechanics issue? Or, there's a lot of things out there like that. A lot of people want to present this material as if, well, is this a pain science problem or is there a biomechanics problem? It's a little strange, right? All these things need to be working at the same time. So if you're taking a client through a new exercise in your gym, is that an exercise science issue or is that a biomechanics issue? You wouldn't say that, right? It applies, all those things apply at once. But humans are tribal, right? We have got 13 different professions here, right? We tend to get together in groups, right? We tend to fight about in-group and out-group issues, right? Taking sides. Tribal and partisan thinking is a big problem. It keeps you from rationally examining things and seeing the big picture. Your brain is not wired to think this way. Your brain is wired to think in that tribal partisan way, right? So I don't want you to take sides. Who knows who Mitch Hedberg is? Yeah. So Mitch Hedberg is a stand-up comedian who sadly died in 2005, but he had this great deadpan style of delivery. One of my favorite jokes is this joke he says about having a death metal band. And he said, I used to be in a death metal band. People either loved us or they hated us, or they thought we were just okay. Now, I can't deliver it as well as Mitch does, but this is the point, is that I don't want you to take sides. I want you to think about taking that Hedberg, right? Approach everything as if it's just okay, right? That lets you rationally examine pros, cons, advantages, and disadvantages, right? So those sweeping generalizations we like to make, that's not so simple. Because we all like to be tribal, right? But who's tired of some of these interprofessional battles that we like to fight, right? I'm tired of that stuff. Look around, as different as people are, whatever the letters behind their name, we're all on the same team here, right? Who's tired of the strength coach versus personal trainer battle? Who's tired of the PT versus chiropractic battle, right? Tired of all these, right? Let's talk principles. Let's talk about things that connect us all. We can approach each question dispassionately when we don't have that kind of tribalism. And when we think even ourselves, what we do, it's not that great. It's just okay. Now, all the frameworks that we're using are wrong. They're incomplete. They're not 100% correct, but some are more useful than the other. You should be able to list the advantages and disadvantages of what you do. You should be able to know some of the contentious issues in your profession and why you have the stance that you do. It lets you rationally examine things. in the strongest versions of their arguments. Remember, we're not special, unique snowflakes, right? All the frameworks we're using are imperfect. Being able to take yourself out of that and look at it rationally is an important part of learning to recalculate your path. The next part of that is welcoming feedback and critique. Who likes to hear they're doing things wrong? Anybody? No, well, a couple people may. I certainly don't often appreciate that. I don't know if my wife would agree with that or not, probably, right? So realize that there's an impulse to shoot the messenger, especially when you feel attacked or when you feel that your tribe is being, oh, I don't know, disrespected or torn down, or you're bashing this approach. Anybody ever heard that on social? You're just bashing. They just like to bash things. So I don't know why they use that term. But surrounding yourself with people who agree with you doesn't make you any better. Being told you're right is nice when it's true, but it doesn't help you grow. So I finally met my colleague Diane Jacobs just yesterday. And so as much as Diane and I agree, we often disagree. Well, maybe we sometimes disagree. And from those disagreements, some of the best learning I've had has come from those situations. People who say you're right and agree with you don't make you better. Nobody gets better by being told what they're doing is right. Now, not all feedback is good. Who's ever received feedback that was off point or just not so helpful, right? We all have, right? You've got to rationally consider that feedback before you reject it, instead of shooting the messenger. The next piece is you got to change with the evidence. Anybody ever heard of this evidence-based medicine thing? I think it's going to take off. So we need to alter what we do and why we do it as the evidence changes. We need to work to find examples of how you have done that in the past and you've changed what you've done. That's part of learning. So I used to be really big into like running shoe selection and fitting running shoes. Anybody ever do that? So I would go from place to place, and I'd have my little basin of water, and I would cut up the paper grocery bags into squares, and I'd have people put their foot in the water, and then they'd step on the bag, right? And they'd step away, and they'd look at me real nervous because they're not sure what I'm going to say. And I sit down there, and I look at their foot, and I stroke my chin. Let's see, looks like you might be overpronating there. And they're like, oh my God, am I going to be okay? I have the shoe for you. Trust me. And so this was a big part of what I did early in my career as a PT. I used to travel. You're the running shoe guy. Oh, I had little flyers about, hey, come learn the right pair of running shoes. Who knows? Silvernail knows, right? So I would sign up and all these people and set them up and give them all these prescriptions. I had all these pre-printed forms. You're either high arch, low arch, or in the middle, and here's how to find it, and here's a couple things to try, and I'd circle the right thing for the right people, and they'd leave with their sheet, and be like, I can't believe I came here. Thank you, Silvernail. And then I started reading the evidence. Well, if you want to be happy with doing what you're doing, you probably shouldn't read the published evidence, because that's continually disappointing. I don't know about how you feel, but that's how I feel, right? So all this stuff that I was so proud of doing, turns out didn't really matter. That fitting people's shoes, feet to the shoes, not the shoes to the feet, the other way around, didn't make a big difference in injury rates. And so I was faced with a challenge. Do I keep doing what I'm doing, or do I change with the evidence? I just kept doing what I was doing, and I charged them more. No, I didn't do that. No, I didn't do that. I changed with the evidence. There's plenty of other things that I had to do. That was an example of where I learned and changed with the evidence. And the more you make a deliberate effort to practice thinking about when you've done that, then that hooks you in with your ability to learn and change, because we've all got it. You wouldn't be in this room if you didn't know how to learn and change, right? And recognize the information that you need to know. We have a responsibility to change what we do and how we explain it when the evidence changes. That's not a choice. That's a responsibility of ours. What you say matters. Jason brought up when he introduced me, of all the things he could have said. I was the guy who really seized on language. Some people would say, well, I think you're just being too picky about that. I said, oh, no, I can't agree. What you say matters. What you say is a direct reflection of what your thought process is. The claims and testimonials you use, the words and phrases that you use, all of those things tell me what you're thinking. And what you say is up for debate and critique at all times. At all times. You're not entitled to your belief. You're not entitled to your opinion. You're only entitled to what you can argue for, what you can successfully argue for, right? Or put another way, Jeff Maitland said it this way: to speak or write in wrong terms means to think in wrong terms. We've got to make sure the terms we use and the thought process we have is aligned with the evidence and with the science. All right, and the last piece, for those of you taking notes, it's the third of three. We must be getting close. I'm so tired after lunch. We need to use claims responsibly, right? So the claims that you use determine your defensibility, and specific claims require specific evidence. When I say claims, we talked about what you're entitled to and what you're not entitled to, right? How you justify your approach matters. You're responsible to argue for and defend why you do. What you do, yeah. Why you do it, yeah. To whom and when, right? That's a professional responsibility we all have. And I'm responsible to all of you for that same thing. We're responsible to each other for that. That's that intraprofessional relationships we've got to have, right? That defensibility of what you do. You can't just do whatever you want, right? Dr. Cook calls that emotional-based practice, right? You've got to make sure that what you're claiming lines up. Watch out for the double fail. The double fail will get you. So the two most common problems when people promote clinical and performance processes are they do the double fail, right? When they fail big, right? So they'll often make a claim that goes against the existing evidence, or they'll make a claim for which there is no good evidence, right? That's our double fail, right? That helps you sort from the good from the bad pretty quickly. But when you're judging claims, you have to actually know the literature to know if a claim is consistent with it, right? So that connects us back to the basic science portion of what we talked about. You've got to know the literature, you've got to know the science. When people make limited and carefully worded claims that don't conflict with the evidence, that's not a problem. When people make limited claims that don't assert something without evidence, that's okay too. That gives us a tremendous amount of leeway to do a lot of really reasonable, thoughtful things for our clients and for our patients. It gives us a lot of leeway to change what we do and to change our experimental and our explanatory model. Now, the client, the patient, they don't have this information, right? Only your fellow professionals do. So the financial planner I use now, his name's Dan. He's 26. He's a very smart young man. He knows a lot more about financial planning than I do. So if I were to come to Dan and Dan would say, well, tell you what we're going to do is we're going to take half your money and we're going to bury it in mayonnaise jars in your backyard. And we're going to stick the other half under your mattress. And so, would I have any idea about whether or not that was an appropriate thing to do with my money or not? Probably not. I don't know that much about finances, right? But Dan's fellow professionals exert pressure on him to treat his clients appropriately. That intraprofessional pressure, that's all of our collective responsibilities. Judging claims isn't hard if you know the science and you apply a critical thinking process. So we can do some practice. So if you're into manual therapy, I do manual manipulative therapy. One of these statements is a little more defensible than others, right? Everybody in here knows the first one's not where we want to be. Apologies to my chiropractic colleagues. If you're in this room, you've left this behind years ago, right? So one of these is a lot more defensible. What about in the world of strength training? I know we've got some performance and fitness folks in the room. There are people who actually think multiple sets are a waste of time. I'm not one of them, but they're out there, right? But you can see the way the claim is worded makes a big difference. And here's a claim for a massage, right? It's, so I wrote that and I couldn't help but laugh as I was typing, but then, I almost had to cry because people really believe that sometimes, right? It kills me, right? So do you see how this gives you a wide berth of things that you can work with and still be defensible and still provide good service to your clients and patients? Remember, it's not your technique, it's not your tool, it's how you use it, for what reason, with what claim, and based on what research that matters. Most common things in therapy, massage, and training can be retrofitted with new information. And the last piece here we'll cover is testimonials. Testimonials are by nature positive and subjective. Consider the ratio of story to evidence. Please use them to illustrate a point that you can defend with evidence. A claim or testimonial full of hyperbole that doesn't make much sense is a major red flag for quackery. I think we all know that. And the last piece is specific claims require specific evidence. So what's a specific claim? I've got a couple examples of the specific claims up there. And when I say specific evidence, what do I mean? Yeah, I mean a citation. That's exactly what I mean. When you make a specific claim, you ought to have a specific piece of evidence. But the citation that you use can't just be any. There certainly are people who like to use the argumentum verbosum process of cutting and pasting 12 million references for their claims, counting that you're not going to read all of them. The citation's got to be applicable to the claim. It's got to be in an appropriate source. It's got to fairly represent the evidence, and it's got to be relevant to your claim. What do you call a claim with no evidence? Well, that's an opinion, right? As we say in the South, some people say cucumbers taste better pickled, right? At the end of the day, you need a navigation system to get through this material. You need a navigation system to integrate this material and move forward with what you're doing, right? Integrating this material is not easy. It is difficult. It is complicated. Reframing your practice and your explanations to line up with the science is our responsibility. Facts are not enough. We do need a systematic decision support process, and we've gone through that. With a little work, right, and a little mental dedication and humility that we all could use, me included, we can really get there. We can arrive at a navigation system that works for us, that works for our patients and clients, helps us integrate this new material and remain defensible and relevant. As you hear the other speakers through the rest of this weekend, if you got your schedule, look quick at your schedule, you'll notice that there's a lot of us that do different things, aren't there? There's a lot of people approaching the same concept from a different angle, and that's okay. Look for the speakers' opportunities to defend what they do. So if you like what you heard, please take the time to go to Soma Simple and donate and help support what we're doing there. This whole process, the people I've met, probably wouldn't happen without Bernard at Soma Simple. Thanks for your attention.
Thank you. So this is your opportunity to ask a few questions before we move on to a break prior to our last speaker of the day. So we do have a volunteer with a microphone. If you have a question or several questions you would like to ask, please, when she comes to you, just one question, and then we will try to come back to you if we can. So if you have questions that you would like, please raise your hand so I can kind of cue you up and let Nikki know where she's got to go. We've got one over here, black jacket.
Not everybody at once now.
Can you hear me? Okay, I'm also in the U.S. Army, physical therapy. So
Cool.
My question is, since enacting this Crossing the Chasm, how has it affected your practice and patient outcomes?
Well, I think in order to make a strong statement about my outcomes, what would I need? I need some evidence, right? And I will tell you that as a general rule, I don't systematically collect my outcomes from place to place as I go. I probably could be a little bit better about that. Within the patient, I'm very good at following them through across an episode of care and tracking their outcomes with validated measures like the Oswestry Disability Index and that kind of stuff. I would say that learning that pain science piece and learning how to cross that chasm has simplified what I do in a lot of ways. It has aligned more of my explanations with good basic science, with good published evidence, and it's made my explanatory models simpler, and I think my patients like them better, right? So tying your explanatory model to the health of the connective tissue probably isn't a good solution if you want to help somebody in the long term feel better, right? So, I mean, I think it's the same thing with the training and conditioning industry too. I mean, we've got to make sure that basic science piece is in place. I think that it has simplified my explanations, and I think my patients appreciate a simple, direct, and factual approach. And I think that most of us in the room probably would agree that that's true of our clients and patients as well.
Next question. While we're waiting for that next hand to come up, I do have a question. So you've talked a lot about the importance of critical thinking and having a process. Would you talk about some of the references or resources that somebody that is working to acquire that knowledge might come to?
Well, I think that when we think about this navigation system, there's a little bit of a self-reflective piece you've got to have. You've got to be able to honestly assess how well you know that basic science, honestly assess where you are in the critical thinking process with respect to those three pieces, see where you are, and start working on the weaknesses that you have, similar to what you would do with a client or patient. I would say for me, learning a clinical reasoning model that is systematic was very helpful. So for me, attending manual therapy fellowship training, I used the Maitland method, the Maitland concept of examination and treatment, and that is really consistent with the basic science and really helps me in my process. I don't require that other people do what I do. If whatever it is, the system that you're using is complete and is a systematic process, includes the basic science and includes critical thinking and includes the claims that you make, I think you're on the right track, regardless of whatever name it is.
We have just a couple of minutes left, and we have a question down here from Alice.
Hi, Alice. One of my questions is, how do I respond to people who have the attitude, what works for me, and they don't care about the science? Like, do you find any approach is particularly good at trying to win people over to wanting to know?
Yeah, the wanting to know. How do I convince somebody that they should want to know why something works?
Knowing I can't control them, but I don't feel effective at that.
Yeah, I don't know that I'm all that effective in that either. And I'm on the podium, so wait a minute. Maybe that wasn't. I think it's important to realize to touch on what our professional responsibilities are to others, to our clients, and to our patients. And it's our responsibility to know that material. It's our responsibility to defend it well. And a lot of people say, well, I don't care if it works as long as it works. If it's placebo, if it's only placebo, I don't care. I'm fine with that. And I guess my best response, which may not be the most productive, is to say, well, if you don't really care why something works, just go all the way and put the witch doctor mask on right now, right? And do the dance, right? Because if that's what you're after, if you're just after any kind of effect you can, then just go all the way. Stop doing it halfway. Go all the way, put the mask on, get the body paint going, do the whole 9 yards, right? And so that kind of professional responsibility piece, I think, is important to touch on.
I actually think that's a good response because it does follow it out to its logical treatment. I
Right.
think most people could recognize it.
Yeah.
And they might not respond right now, but maybe down the line.
Yeah, finding that chain of reasoning's pretty important. In my interactions on social media, I try to appear the sensible, rational person, which I don't always succeed at. Believe me, a brief search will find scary things. But keep in mind that as you talk about those things, when you have those kind of discussions with people, don't use the person you're talking to as the target. When I'm having these discussions with folks where I disagree with on social media, which happens a little bit, right, honey? A little bit. I'm not targeting what I'm saying to the person I'm having a conversation with. I'm targeting what I say to the people who are reading along and not participating. Sometimes in web parlance, they call those folks lurkers. Those are the people that I'm looking to influence. I'm not looking to butt heads with somebody and change their mind. I'm looking for people who are not involved in this to watch the discussion from a third-party view and see someone making a organized and reasonable case and laying the arguments out about why they do what they do without trying to force a solution onto someone else. In order for someone to listen to you, they have to be moving towards you. You can't chase them down, right? So in order to move towards you, they've got to see that your message is worthwhile and that you're someone that they'd like to listen to.
All right, I think we have time for just one last question in the back row here.
Hi, I'm Susie. I am a physical therapist, and I agree that we don't want to wear the witch doctor mask, but I think that we need to take advantage of as many of those placebo things that we've heard about earlier, like, for instance, wearing the tie or driving the nice car.
Oh,
That's
yeah,
gonna
could you
make
help me
our
with the
clients
driving the
feel
nice
better.
car part? That'd be great. I have the tie already. Right?
I'm just saying.
I do think that what we don't want to do is we don't want to set up an either-or position, right? We don't want to set either it's all placebo or it's zero placebo. No, it doesn't work like that. the core of what we do has got to be scientifically defensible. Then on top of that, remember the graph earlier from Dr. Mosley, we've got to understand what those non-specific effects, what those placebo effects are, and work to maximize them for the benefit of our clients and patients. Those are the people to whom we're most responsible. So let's not say that those things are bad. That just shouldn't be the entirety of what we do. Does that help? We need to maximize those effects while providing defensible processes of care.
All right, that brings us to the end of our question and answer session. If you have additional, yes, this would be a good time to applaud.
Yes, clap, please. Thank you.
And so we are going to go into a 15-minute break. We will be back for our final speaker of the day, and